Two, one, we are live, sir.
Hi, good evening, everyone. Ladies and gentlemen, I welcome you all to second round of crossfires in endourology. Uh, all participants are ready. This is a debate between North Zone and East Zone. Before we begin, I will invite our dignitaries to share their thoughts. First of all, will be Dr. Rajiv TP, followed by our President, Dr. Anant Kumar, and then Chairman ISU, Dr. Rajiv Sood, and Dr. Arvind Ganpole, who is the convener of this endourology session. So, can I request you to start without delay of Dr. Rajiv TP's address, please?
Good evening, everyone. President, Urological Society of India, Professor Anand Kumar, Indian School of Urology, Professor Rajiv Sood, Co-Chairman, Indian School of Urology, Dr. Arun Chawla, the convener of the Endo Subspecialty section of USI, Dr. Arvind Ganpole, my dear members of the Urological Society of India, residents and members from SAARC countries. Today we are having the second round of this wonderful program, Crossfires in Endourology, conducted by the Urology Subspecialty Session of USI ISU. As you all know, that the first round was a grand success and there was a good participation from across India and the SAARC countries. And after a very tough debate, we have selected for the second round the participants. Again, the endourology subspecialty session has carved out a wonderful debate journal wise. Today we have between the north and east and west and south, and another session on the residents, and the winners will now go to the round 3. This is a very interesting program, and this has been well appreciated by many in the previous round. Now I wish all the participants a very good luck, and the endourology subspecialty session a grand success. With this few words, I welcome you all again for the round 2 of the crossfires in endourology. Thank you.
Good evening to all my friends. I bring greetings from Urology Society of India, and I am very happy to see that endourology crossfire debate has reached to the second round. This is a very healthy sign that our members are debating each other, trying to tell their points in a more emphatic and scientific way, and this way everybody is learning. Debate is a very good way of learning, because you hear the viewpoints of two persons talking on same subject with different point of view. So after listening to that, you can take your own call and decide what is best for your patient and what you want to do it. And debate also brings out your desire to argue and desire to bring your own point and desire to win. So this is a competition, and there will be a winner, but we appreciate participation of all the debaters, and we will congratulate the winner, but we also appreciate and congratulate all the participants who have participated in this wonderful webinar. Endourology is a very important aspect of all of us, because it is our bread and butter, and almost all urologists practice endourology, and there are many controversial points which we are debating, and we know there is a different ways of skinning a cat, and one wants to know which is the best way. So by debating, you may get an idea and you may choose the best way to treat your patient. With this, I would like to pray for the good health of all my members, their loved ones, their families. Please stay safe, practice all the safety guidelines, and with this I welcome you again with USI ISU webinar and Crossfire in Endourology round 2, in which West Zone and South Zones will be debating, and participants will be residents and consultant both. Thank you very much.
Good evening, friends. Along with President Anant Kumar, Secretary Dr. Rajiv T, my co-chair Dr. Arun Chawla, I extend warm greetings from Indian School of Urology. Endourology subsection, subspecialty section, Dr. Ganpule has crafted wonderful program, and we have completed our first phase. That was the round 1 on 16th of December. 23rd of December is going to witness interjonal debates. That will be South versus West and East versus North. And after that, we will be choosing the winners of the debates, and these winners are going to further debate in the third round on 23rd of December. Simultaneously, there are going to be resident rounds, and that is also second round. And in this residence round, which will ultimately conclude in balloon round, this time we are having 3 debates. With this wonderful program, which was conceptualized by Dr. Arvind Ganpule along with the other team members, we are very successfully marching forward in the subspecialty and in the vision of subspecialty based functioning of USI. This is the great times when we are ending our year, and with the greetings for the new year, more academic fees, more academic activities, webinars, distant learning. I wish all the members of Urological Society of India, all the delegates who are witnessing from India, abroad, and especially from SAARC countries, and residents as well as the consultants who are participating, all of you may have happy festivity season, happy more academic activities, and let this corona timings end with the end of year 2020. Thank you.
Good evening, seniors, friends and colleagues. I am Dr. Arvind Ganpule. I am the convener for this debate program. I welcome you to the USI ISU debate contest round 2. 15 days ago, we had witnessed an academic extravaganza wherein we had got intrazonal debate contest, and we look forward to have an round 2 of a similar academic extravaganza today evening. Today we have an interzonal contest wherein the North Zone debaters will clash with the East Zone debaters, and the South Zone will clash with the West Zone debaters. In addition, we have got the Young Turks, that is the residents, who will be debating in Zoom ID 3. So in all, we have got 22 debaters who will be debating in 11 debates. So it's time to enjoy ourselves. All the 3 Zoom IDs will run simultaneously at the same time. The winners of this round enter into the round 3 as well as the grand finale. The debaters are being adjudged by a team of very experienced judges, and I must stop for a second to acknowledge the contribution and services of these judges, who are stalwarts in their own field but have agreed to spare their time and have consented to adjudge the winners. Most important, by keeping themselves in anonymity. Thank you, sirs and madam. I must also thank the veteran innovators who have kindly agreed to give us the recorded guest talks. Actually, they do not require any introduction to this august audience. We have got Dr. Mahesh Desai, who will be talking on how the idea of microperk occurred to him. We have got Dr. Janak Desai, who will talk to us as to how the idea of UMP came to him, and then finally Dr. Kaushik Shah would be talking on Super Perk. Thank you, Mahesh Desai sir, Janak Desai sir, and Kaushik sir for consenting to be on this program. Your talks will indeed inspire the future generation of innovators. I would fail in my duty if I do not acknowledge my colleagues, Dr. Deepak Ragori, Dr. Rahul Gupta, Dr. Singh, and Dr. Zishan, and of course Dr. Karthik from Trichy, who have helped me out in this endeavor. My special thanks to my colleague Dr. Rohan Batra, who has been helping me in the back end. Thanks to Mr. Fani Kumar and Ms. Suruchi Kandalkar from IPCA Laboratories for doing the all back end job and managing the AV. Professor Rajiv TP, Professor Raju Sood, and Professor Anand Kumar have been the backbone of this program, and I must thank them. Last but not the least, we all will agree that round one we witnessed a very few intense, strong, and academically robust debates. I must thank all the debaters for preparing so well and for giving their active participation. I wish all the debaters the very best. Thank you.
I thank our President Anant Kumar sir, Dr. Rajiv TP sir, Dr. Rajiv Sood, and our convener Dr. Ganpule for sharing their thoughts and setting the rolling the ball and setting the things on fire. I will hand over to my co-moderator Dr. Arvind to take us further for the debates.
Thank you so much, Harpreet, for that introduction. We straight away go to the debates. There is a slight change in the sequence in which we are going to debate today because of some unavoidable reasons. So we are going to take debate 4 as debate 1, and debate 1 will be exchanged as debate 4. So the first debate is between ECIRS versus PCNL. Just to give you a short history so that the whole thing will be put into perspective. This is a 64 years old gentleman and hypertensive since past 15 years. He complained of left flank pain on and off for the last 2 years with history of lithoria since past 6 months. No other complaints. And he presented with this particular picture. You can see that there is an partial staghorn extending into the pelvis, lower calyx, multiple stones, and there is one more stone in the upper calyx. A further imaging shows that it is an dilated middle and upper calyx with a stone in the upper calyx and an partial staghorn extending into the pelvis and lower calyx. You can see the size of the stone. A little bit further information with this coronal images. You can see the distribution of the stone in relation to the imaging findings. A little bit more information. So we have got two experienced debaters, I must say now, from my experience of the last debate. We have got Dr. Akshay Batta, who will be debating in favor of ECIRS. And then we have got Dr. Saptarshi Mukherjee debating in favor of PCNL. We first start with Dr. Akshay, then Dr. Saptarshi, and then we come for the rebuttals. So Dr. Akshay, I'll stop sharing my slide and you can come forward and give your presentation.
Yes. Good evening, sir. Is my slides visible, sir?
Yes, very well. Make them full screen, ready to go.
A very good evening to all present. I'll start with the case straight away. So this was the index case given to us. And we can see there's a upper calyx stone and also a partial staghorn in the lower calyx. And also this was the anatomy given to us. And so, sir, my approach would be a best of both the approaches of RARS and miniaturized PCNL. So that would be ECIRS. So in order to reach my goal, the following factors I'll have to consider. It is the patient, the anesthetist, the surgeon, and also the hospital. So one by one, I'll speak about all of them. So for the anesthetist, how is it advantageous for my anesthetist? So ECRS, as you know, will be done in the supine position. And also, so ECRS can be done in the spinal anesthesia. And it also can be given in the recovery area in order to save time. And the anesthetist will be very comfortable and has complete airway access. And also conversion to general anesthesia in case of a longer procedure can be done. Also, spinal anesthesia has better post-operative analgesia, and also a very important advantage in today's pandemic era would be that almost many cases are we are seeing anesthesia comfortable doing under spinal anesthesia. So also all the cardiorespiratory parameters, they are much favorable while operating in a supine position rather than a prone position of standard PCNL. So keeping my patient safety into consideration, how will it affect? Obviously, we are not turning the patient prone, and so the patient will have less risk of various musculofacial injuries, subconjunctival hemorrhages. Also, perioperative vision loss has also been reported when we turn the patient prone and procedures are prolonged. Also, a patient will be saved from any neurological injuries like brachial plexus injuries and also peripheral nervous injuries while turning the position. So another important factor is bleeding. The bleeding chances will be less in our procedure because this procedure can be done mostly by only a single puncture. So as we can see, this is reflected in the transfusion rates also. ECRS fares better than supine or prone PCNLs. Also, the rates of infection, urinoma and sepsis will be lesser because first of all, we're going with the lesser tract size. There will be infracostal puncture and thus the less possibility of any rollover atelectasis. Also, since the irrigation, since the sheath is positioned in a comfortable position and the water can escape with the help of gravity, so there will be less intrapelvic and calyceal pressures. Also, there will be reduced vascular intravasation and fluid leaks. Also, the colonic injury chances will be less because, as we know, retrorenal colon is encountered most in prone position than supine. And in special cases like this patient, this obese patient, and also in patient having deformities or other cardiorespiratory diseases like COPDs, and also elderlies, and also patient having motor neuron diseases where positioning will be difficult. So such an approach will be better. So coming to for surgeons like us, how is it favorable? Surgeons can, it is, first of all, it is ergonomically very favorable. A surgeon can operate in a sitting position. It has less radiation exposure because our hands will be away from the radiation field. Also, there will be endovision control of all the steps of the procedure from puncture to dilatation. So we obviously won't require that much radiation, and a mean exposure time, radiation time was calculated to be around 3.3 minutes in a study. So technically, how will it will be advantages? First of all, we'll do a retrograde ureteroscopy for evaluating both the lower and upper tracts. So endovision guidance will be there for choosing the puncture, for dilatation, for advancement of the sheaths, basically for all the steps, and also it will minimize any under or over dilatation. And also a retrieval of guide wire through and through will be possible. See how the guide wire we can moves towards the ureter, and how precisely we can see all the steps. And another, there will be bilateral antegrade and retrograde irrigation will be possible. And so it will be helpful in a better endoscopic vision. And also the spontaneous passage of very small fragments will be seen as when we can push the saline from below and fragments will remove by themselves. And also there'll be exploration of all the calyces will be greatly improved by combined nephroscopic and ureteroscopic approach. And they'll be reduced. Another important advantage will be a reduced need for multiple accesses. And I have gone through series which have reported almost a single access, single tract in almost 100% of the cases. And these are series more than 150, 200 cases also. And another big advantage of this technique will be a unique and big advantage is pass the ball technique. See, a stone in a different calyx can easily be brought down into the vision of the nephroscope with the help of our ureteroscope. And this will be especially advantageous in our case. See, there's a stone in the upper calyx and also a large stone in the lower calyx. When we approach from below, obviously we can easily get this stone from the upper calyx and into the vision. And also we can remove from the same puncture, and thus we can avoid a supracostal puncture also. So how the results are there? There was a review.
1
this
minute
latest
ago.
review showed the stone free rates to be better than those of the PCNL. And also the complications rates were also reduced because we are going through a single tract, and unless multiple tracts in other PCNLs. So for our hospital, how it will be advantageous? It would improve the quality of the life of the surgeons and the staff, because they'll not be subjected to positioning of heavy loads, heavy patients, and thus they will not strain their backs. For the cost benefits, less OT staff will be required. Also, the procedure can be done under spinal, so less monitoring and less specialized equipment will be required. Also, time will be greatly saved, because we don't have to turn the patient from supine to prone, and also prone to supine later on while extubation. So overall time gets reduced. Also, better services can be provided, because OT will run faster. There will be lesser bleeding, less transfusion and complication. This will reduce the bed occupancies. And also stones can be cleared more efficiently in a single sittings, and no needs of any review procedures. So overall, I would say that it is a win-win situation for everybody, and thus ECIR will be the way to go in this procedure, in this case. Thank you.
Thank you, Dr. Akshay. Great points. But let's hear what Saptarshi wants to say. Dr. Saptarshi, let's hear what you want to say. You can unmute yourself.
Sir, am I audible?
Yes.
Okay, sir. So just a minute.
Okay, the slides are seen. You can make it full screen.
So is it visible right now?
Yes, it is visible.
A very good afternoon to all of you. So here, actually, I'm here to choose between a time-tested procedure and a new one. So is this debate really about which is better or has more advantages? No. Which is unique or has got lesser complications? No. Which has got a better stone clearance? Definitely no. But whether to select an apt and optimal surgical procedure for this 64-year-old gentleman with predominantly lower calyceal and a solitary upper calyceal stone, and with the basic understanding that we should use a particular thing where it is supposed to be used, and not only because we have it. So, is it really justified in this case to replace a gold standard procedure with a new technologically advanced procedure? Let us see this. Is PCNL the gold standard? It definitely is. If we look at the AUA guideline or the EAU guideline or this particular study from BJU, which has encompassed a lot of international guidelines, all have concluded that PCNL is the treatment of choice for more than 20 mm stones, including partial or complete staghorn. Now, I have got loads of PCNL modifications. As my friend was really concerned about position, I myself can carry about a supine PCNL in this case, thus negating the side effects of prone PCNL. And there are other options also. Now, let us see at this CT film. Now, from this moderately dilated upper calyx, a supra 12th puncture will suffice. And this will be a single puncture, following which a mini perk can easily retrieve all the lower calyceal stones. But definitely, there will be people in the houses who will be cynical about carrying out a supracostal puncture. But is this fear really evidence-based? Let us see at this comparative evaluation between upper and lower calyceal puncture. And they have shown that the success rate is much better in upper calyceal puncture group than the lower calyceal puncture group. Moreover, in a non-operated mobile kidney, puncture through the supra 12th approach minimizes lung and pleural injury. Now, even if a single puncture is not efficient, can't we go for a multiple puncture? Is it really that dreadful? If we look at this study from the Asian Journal of Urology, they have mentioned multi-perk is really safe, feasible, and effective for management of large burden, complex renal calculi, and it is cost-effective also. This is another study for renal staghorns published in the same journal, and they have mentioned that there is hardly any difference in the complication rates between the single-tract and multi-tract approaches. In fact, the need for transfusion correlated with a lower pre-op hemoglobin and a higher pre-op serum creatinine. So of paramount importance is patient selection and judicious planning for the puncture. But still, if there have been concerns regarding loss of renal function also in multi-tract, but studies have shown that the mean scar volume is negligible in comparison to the healthy renal volume. So PCNL using multiple tracts is definitely safe and effective and exhibits a similar safety profile to a single tract access. Now, but still, people will still be afraid of carrying out a supracostal access or a multi-tract. Then we can get hold of a flexible nephroscope. This study has shown that flexible nephroscopy is associated with a higher stone-free rate with fewer indications. This is another Chinese study regarding the management of renal staghorn, and they have shown that flexible nephroscopy has got an increasing procedural stone-free rate even via a single nephrostomy tract, that is single puncture, and this was a very significant fact. Now, let us see the role of ECIRS. Whenever we do search for the role of ECIRS, be it a Cochrane database, be it PubMed, Google, or everywhere, we do come across few terms like its role in the management of staghorn, its role in extra large renal calculi, in post-PCNL residual stones, or even in treatment of large or complex urolithiasis. But let us summarize the actual indications of ECIRS from this Asian Urological Guideline. They have mentioned it is to be considered for large and complex stones, concomitant ureteral stones, contralateral renal stones, and patients with renal anatomical deformities. But does our case really fit into those categories? Let us not see. Here, actually, we are seeing a CT film of our patient. Doesn't it look very similar to the CT films that we often encounter in our day-to-day OPD practices? Truly speaking, how many times do we really recommend ECIRS for this group of patients? But however, let us not leave it to subjective perception. Let us look at this study on nephrolithometric scoring to predict PCNL outcome. For our case, the stone size being around 22 millimeters, a moderate tract length, mild to moderate obstruction with 2 involved calyces, the stone score comes to around 5 or 6. And studies do show that stone score of around 5 had a high stone-free rate of around 94 to 100% even via conventional PCNL. This is further enhanced by this particular flow chart in the Asian guideline, where our case has got no anatomical abnormalities, no concomitant ureteral stone. And regarding lower polar burden, they have mentioned ECIRS to be considered in patients with more than 20 mm lower polar burden, whereas in our case, it's only 12 millimeter. So we can definitely go for a mini PCNL, or even ultra mini or micro pulp can do wonders in this case. Regarding complications, for PCNL, we all know that. For ECIRS, theoretically, it is not only attributable to PCNL, but can also be due to the RIRS part. From this randomized control trial between mini-PERC and ECIRS, we do come across that they have mentioned that not only the mean operative time is longer in the ECIRS group, but no statistical difference was found in regards to the clinical complications also. So, as my friend has nicely depicted a video, is he considering a real-time ECIRS to be used in this case? If it's that, let us see at this OT setup. Just imagine how many times in our Indian scenario have we come across such an OT setup with 2 video monitors, 2 light sources, and 2 urologists. So if we consider the cost over here, it will not only encompass that of PCNL, but also that of the flexiscope, the laser machine, the additional light source camera, and definitely the second urologist. So does it really seem reasonable for this sort of a case to go for ECIRS? So if we do compare for this particular case, not only the stone-free rate and the complications are comparable, I can, or many other urologists can go for a single stage PCNL based on the modifications I have mentioned. And as far as ECIRS is concerned, I really doubt whether any of the urologists can go inside the OT without taking a prior consent of requirement of a degestenting. And for cost, resources, manpower, I don't think any comparison is required at all. So you may have a Mercedes-Benz E-Class, but it doesn't mean that we need to go for a grocery shopping with that. So we are lucky that we are blessed with all the resources right now in the modern era, but we should really learn and try to use them wisely and appropriately. Thank you.
Thank you very much, Dr. Saptarshi. Very compelling argument, but I'm more than sure that Dr. Akshay has got a befitting reply in the rebuttal for him. So, Dr. Akshay, can we listen to your rebuttal?
Yes. Sir, is it visible?
Yes, it is visible.
Sir, but slides are not going. 1 second, sir.
Okay, take your time. The slide is visible, Akshay.
Yes. Oh, okay, sir. Now moving on to the rebuttal. See, first of all, I would like to say that yesterday's luxuries have become today's necessities. See, we have come a long way from bullock carts to cars, and now we have jets that can take us to even far off places within minutes or hours. So, and same way, our field of urology has also advanced a lot, from previous scopes to newer, advanced, and to flexible scopes, and also the stone fragmentation has also from pneumatic. It has moved from pneumatic to lasers, and so with time we should change, and this becomes necessity. What is there today? See, as we can see in the image, there are two pilots which are two viewpoints are always better. See, these are two pilots which coordinate amongst themselves and to have a perfect and safe landing. And similarly, there are two viewpoints here also. We can visualize the system, the stone, everything we can, and control from by the coordination of the two monitors. We can coordinate and precisely we can go for the all the steps of the procedure, and also we can make the patient stone free and give minimum possible complications to the patient. Also, my friend told that he is more comfortable doing multiple punctures for the case, and also supracostal puncture. But what is the need when you can do with only one track? And multiple punctures obviously are known to cause more bleeding, more complications, more nephron loss and all. Also, he was concerned about the equipment cost. So also I would like to say that even open surgery costs, equipment cost is not much. So does that mean we should revert back to open surgery? I would like to ask him. And also, see, I'm not telling you this is going to be easy, but I'm telling you this is going to be worth it in the future. And also, see, I have enough evidence and enough the stone free rates are there. They don't results speak for themselves, they don't lie. So it will be a way to go in the future. Also, ECIRS has everything and much more than what a RIRS and PCNL can offer. So if one has the advantage, if one has to choose between either of the two, why can't he choose a combination of the two which is more advantageous for himself and also for the patient? So thanks.
Great points, Dr. Akshay. And I'm really eager to listen to what Dr. Saptarshi has to say for those slides.
Hello, sir. Am I audible?
Yes, you are audible. You can
Sir,
start
actually,
sharing
my
this.
computer got shut down. Sorry, sir.
Yeah, no problem. You can start sharing this slide. You're on time. No problem.
Okay. So is it visible?
Yes, it is visible.
Okay, so my rebuttal will actually be reinforcement my already stated facts. As my friend has really been skeptical about carrying out multiple punctures and supracostal puncture, just to reinforce that, let us look at this particular study. They have specifically mentioned that the mean hemoglobin fall and the mean creatinine rise are hardly any different between a multiple tract procedure and a single tract procedure. Moreover, the same goes with the supracostal puncture study published in the Indian Journal. They have also shown that the fall in hemoglobin and the blood transfusion requirements are not different between a supra 12th and an infra 12th puncture. The important thing is I am talking about a supra 12th puncture, not a supra 11th puncture, which won't be required perhaps in this particular case. So even if they are still afraid of carrying out those two processes, just look at this image. We can go for a lower calyceal puncture followed by negotiation of a nephroscope to retrieve the upper calyceal stones, and that will be a single puncture, as I've already mentioned. So studies can actually be misleading. If you look at this ECIRS study, they have mentioned that ECIRS is not superior to PCNL in terms of urological results. But in this meta-analysis, though they have mentioned the superiority of ECIRS, the problem is there were only few studies comparing ECIRS and PCNL head to head. So they did select very particular complex cases, patients with anatomical deformities, to avoid the risk of bias. So the important thing is the indications of ECRS still now needs to be revalidated till now before we start using them irreplaceably. So till then, let's not make things very complicated and let's use things appropriately. So have a simple living and a happy living. Thank you.
Thank you, Dr. Saptarshi. That was really very interesting. And I'm sure that the judges are going to have a tough time in deciding who is going to be the winner. But I leave it to there and we go straightway to the next debate, that is debate number 2. Here we are going to debate on prone PCNL versus supine PCNL. I'll start sharing my screen so that I can show you the case that we are going to debate. So as I just mentioned that this debate is between a prone PCNL and a supine PCNL. And the index case that we take here is an 68 years old female. She's a hypertensive since 10 years, complaining of left flank pain on and off with nausea. A little bit obese, you can say a pot belly sort of anatomy. And this was the stone lying in the renal pelvis. A little bit more information on the imaging, you see that there is moderate dilatation of all the calyces, the superior, middle, and the lower calyx as well. And you can see that we have got an pelvic stone here. The ureter is very well delineated and equal dilatation of both the calyces, upper calyx as well as lower calyx. Good infundibulum, I must say. These are the reconstructed images showing the posterior and the anterior calyces. So here we have got these two stalwart debaters. Dr. Vijay Madhuri would be debating in favor of prone PCNL, while Dr. Rajendra Prasad Roy would be debating in favor of supine. We first start with Dr. Vijay Madhuri. I stop sharing my screen and I invite Dr. Madhuri to start his presentation.
Okay. So is my screen visible, sir?
Yes, you are visible very well. You can make it full screen and start.
Good evening, everybody, to the audience, and good evening to my opponent, Dr. Rajendra, who is actually my senior. Greetings from Jodhpur. So straight away going to the case. This is a 28 kg per meter square BMI female with this stone configuration, pelvic stone. And what do I want to do? Prone PCNL, no doubt about it. Why? Let us see. So what actually we are deciding about, which procedure has better chance at a stone clearance, complete stone clearance, which is safer, which is easier to perform in a reasonable time frame. Now, stone clearance is very important here because in both the procedures, either prone or supine PCNL, we are punching hole in the kidney. And this is not a small thing, and I better do a complete job if I'm going to do it. So how do these two compare? Actually, there is no comparison. This is a very recent meta-analysis in Journal of Endourology. 13 studies, 6 RCTs and prospective cohorts. Significantly higher stone-free rate in prone position as compared to supine position. You can see the p-value there. And this is again a large cohort. Very interesting study. They have compared actually the centers which are solely performing supine or prone PCNLs. So as you can see here, even in centers who are performing only supine, they don't perform prone. Even there, the stone free rate is significantly lower than the prone performing centers. See this, 5,800 patients in 96 worldwide centers. Also, please keep in mind the data and the level of evidence. Now, this is a paper. Ironically, the first author is Valdivia himself, who is the proponent of supine PCNL. He himself acknowledges in this study, overall stone-free rate is better for prone PCNL as compared to supine, and this is a significant difference. Again, another recent prospective randomized study, again stone-free rate significantly in favor of the prone group. So no question about it, better stone-free rate I'm going to offer only by prone PCNL. Now let us see which one is safer, prone or supine. So this is again another RCT. So I am all giving only level 1 evidences, and after listening to this, I don't think there should be any doubt about it. See, the mean blood loss, mean hospital stay, major complications and minor complications, both are equivalent in both the groups, supine and prone. The difference is not significant. So some guys may argue that supine is safer and this and that, but no, this is not like that. Randomized control studies, level 1 evidence, supine and prone both are equivalent in terms of safety. Then actually in some cases, the prone position may be beneficial. Prone PCNL with general anesthesia, it actually minimally affects respiratory mechanics and improves the functional residual capacity and increasing oxygen tension. And you don't need to go very far. We are in the midst of a pandemic. You all know that prone positioning is used for COVID-19 ventilated patients. It actually improves the hemodynamics and the respiratory parameters. Another meta-analysis, just to see the complications, you can see here P.16, no significant difference in visceral injuries between the supine and the prone. I am sure my opponent has some data regarding supine chances of visceral injuries, but please keep in mind this is data and people may present anecdotes or theoretical considerations, but this is hard data. Again, blood transfusion rate 0.1, no significant difference between supine and prone positions. This is a meta-analysis. So prone PCNL is actually safer than the supine PCNL, and if not, actually it is even equivalent. So in these two parameters, prone scores. Now let us see the ease to perform. This is very important. There are a lot of things to consider actually, the time to gain access, the standardization. Let's look into all of this one by one. Now see this. This is a big issue in supine PCNL actually, the lack of standardization. We actually don't know which position is good, how to keep the patient. There are actually 12 or 13 positions described. It's very confusing. All these point to the fact that it's not standardized. The results have not been replicated in any other center. In all the centers, the results are not the same. This is the problem with supine PCNL. Now see this very good study, and people keep telling me maybe less chance of visceral injuries. Not like this. See this, a supine position, see the tract length. This is the same patient in the supine and the prone position. The tract length is significantly longer from the skin to the calyx, and here it is significantly shorter. Also see this perpendicular line. The calyx and the puncture tract are quite far away from the most nearby structure, but here there is so much proximity. As you can see, these are all theoretical considerations that supine is safer than prone. See this index case. You are going to almost go in this plane parallel to the table, horizontally needle if you are doing supine PCNL, and there is a bowel interposition here. I am sure this is in close proximity to the puncture area, and I am actually scared about performing supine PCNL here. Then this is not actually a theoretical issue. See here, I have the data. This is a group which performs a supine PCNL. They have compared it with the prone technique. See this prone and supine, the dilation difficulties, no difficulties in prone, but 6 difficulties. P-value is significant. They have found it significantly difficult to perform the supine PCNL. Now see this. I don't understand where actually there is a good space to go in maneuver your nephroscope. This is the 12-3 biliac crest. This is the small space which you are actually seeing. And now, again, regarding this case, in supine PCNL, probably you'll go through this track. The stone seems impacted. I'm not sure by this angle of entry, you can negotiate your guide wire down the ureter. And even here, if you are able to park it, is it going to stay, the guide wire? See this, regarding the amplage sheath, authors have recommended that it may be secured to the skin to prevent it from falling. So when amplage sheath itself is falling out, how do I expect the guide wire to be parked? It's going to be really tough. And more difficulty, more complexity, there are increased chances of errors. See this editorial comment again on a prospective randomized trial. It took 60 cases for the authors to learn how to gain access in the supine position. They were experts at doing prone, and for supine, they took 60 cases, they crossed the learning curve, and then they could complete this RCT. Very significant matter. Again, this is a comparative study of prone and supine. Very important points. In supine PCNL, the tract is more medial. There is greater mobility of kidney, leading to invariably longer tract length, which means that you have to place more torque and there is increased chance of blood loss. So I don't know how supine is safer. Now, bailout option is also very important. Suppose you're having a bad day. It's not uncommon that you are unable to get a tract in the chosen calyx. So yeah, okay. Prone, we have to choose a different tract. I can go from the upper calyx, but in supine it's going to be very difficult. What to do, I don't know. And reasonable time frame. Actually, whatever you may think and say, the prone takes less time than the supine PCNL, and supine PCNL is actually faster. Again, see this important study. In RCT also, this has been shown, the prone takes lesser time. So all these points are favoring prone PCNL. So I think if you position the patient correctly, half the operation is done. So please do a prone PCNL in this case, and that's better option to go. Thank you.
Thank you very much, Dr. Madhuri. Very nice points, but I'm sure Dr. Roy, being your senior, he must have a few advice for you as well. So let's listen to Dr. Rajendra Prasad Roy. Dr. Rajendra, you can start sharing your screen.
Yes, sir. Sir, it is visible?
Yes, it is visible. You are audible as well.
Okay, sir. Good evening, Chairperson USI, my senior junior colleague, my junior and friend, Dr. Vijay Madhuri. Today, the topic of debate is prone versus supine PCNL for a renal pelvic stone. My case is 60-year female who is hypertensive for 10 years, having a symptomatic stone disease for 2 to 3 years. He is slightly overweight. There is a single stone which is quite large, 17.5 into 15.4 into 12.3 millimeter, and it is quite hard. 1350 is the Hounsfield unit. So considering all the fact, the reasonable choice of operation is percutaneous nephrolithotomy. Whether it is prone or supine, should we debate on it? I just want to tell you one thing. The prone is the position, not the procedure. Procedure is the PCNL. So PCNL can be done in different position. What it doesn't matter. The only thing is the result that matter. Now, if you go through the American Urological Association or European Association of Urology, these two strong body who recommend urologists for the guideline of the different urological procedure. But none of the guideline has suggest that PCNL, none suggests the position of the PCNL, which one is superior. Now, surgical positioning is the practice to place the patient in a physical position during the surgery, but the goal is foremost maintaining patient safety where gaining access to the surgical site. Now, over the years, we continue to do it on prone because it is first described, but what we forgot is patient safety and comfort. Now, if you see these pictures, these are because of the prone positioning. And so you can realize that clearing stone is not only the thing, safety of the patient is far more important than the success rate of your surgery. Now, performing PCNL procedure requires a prone position is challenging and requiring special attention from the anesthesiologist. Now, prone is a nasty position, and different, apart from the other positions, the problem of the prone position, if you ask your anesthetist, he will tell you that it reduces the functional residual capacity, and that requires increased tidal volume leading to barotrauma. It reduces cardiac index. There may be accidental extubation that lead to hypoxic brain damage. There is decreased cerebral outflow and increased intracranial tension. There is increased intraocular pressure leading to blindness, facial swelling, macroglossia. And in case of cardiopulmonary event, there is difficult resuscitation, and sometimes you may lose the patient. During the position, there may be accidental fall, there may be brachial plexus injury, orbital injury, facial skin necrosis, spinal trauma. There may be accidental pulling of the urethral catheter and tube. And it has been shown that in different papers that At least 1/3 of the patients of the prone PCNL develop complication, be it urological, maybe it is non-urological. It needs special OT tables, supports, and trained OT staff. On the other hand, supine position is always preferred. It is safe and comfortable, not only for the patient, for the anesthesiologist, for the OT staff, and it counts on the surgeon. What we gain? We gain different disadvantages of prone PCNL rather than advantages. The patient must be repositioned from the first stage. There is increased operating time. There may be injuries. And in certain patients like ankylosing spondylitis or other spinal deformity, it is difficult to put in prone, and there is greater risk of radiation. On the other hand, there is the advantages of the supine PCNL. It is easy to perform, reproducible technique, has a smaller risk to radiation, a more comfortable working position for the urologist. Callus puncture actually easy, and it can be executed with a needle that follows the perpendicular path. It facilitates the spontaneous exit of the many stone fragment, and simultaneous supine PCNL and URS can be done, so ureter can be accessed simultaneously. Now look at the meta-analysis. This is the meta-analysis which suggests systemic review meta-analysis that include 2 randomized control trial and 2 case control studies including 389 patients, that is published in Journal of Endourology in the year 2010. They suggest that there is no differences in success rate, complication rate, transfusion rate, and fever rate, but there is always shorter operative time in supine position. And they conclude that supine PCNL is an alternative to the prone PCNL, and the hazards of the anesthetic and the problem can be reduced in supine. Another study which is published recently, 2019, in International Journal of Surgery, where include 15 RCTs with 1474 patients. And they found there is no significant difference in stone-free rate, hospital stay, and overall urological complications, but there is reduced over time. They also opined that PCN in supine position could be a safe and efficient choice for the patient with renal and upper uretary patients. This is another meta-analysis. So level 1 data published in Urological Journal in 2016. Stone-free rate is similar, the operation time is similar, hospital stay, complication rate, all are similar, but there is less blood transfusion and less infective complication. So they suggest supine PCNL may have advantageous position, especially in the patient with comorbidity. It includes 7,733 PCNL cases, where supine only done in 1/3 cases. Now, supine PCNL is feasible in children. It is safe because it is published in a Journal of Scientific Society, where they conclude supine PCNL in children is feasible, safe, and effective means for management of renal stone in the pediatric population. And it carries advantage of the surgeon who can perform in a sitting position, avoid changing position, the beginning and the end, and associate less chance of hypothermia fluid absorption. Now, it is in the 1987, it has been conclusively proved that if you place a patient in the prone, there is a chances of retrorenal colon almost more than 5 times than the supine. So the chances of injury is also in the prone position. Now, this is from the author who have first described the supine PCNL, who wrote after 2 decades of he performing supine PCNL, wrote to letter to editor, which is published in 2009. He said, from our point of view, the percutaneous nephrolithotomy performed with patient in supine position offers such a wide variety of advantage that we still do not understand why the majority of urologists insist on following the same routine. Sadly, day by day, they go on stumbling with the same inconvenience of the prone decubitus. Now, this is another publication in 2011 where supine versus prone PCNL has done. This is the largest study, I think. But the sub analysis suggests that prone is slightly better, but actually there are fallacies because these include the global scenario. There are paucity of data. There are supine PCNL is ignored for more than 3 decades. So and it is only for the 1 decade when PCNL has been taken up. So these data in favor of slightly in the prone PCNL, but they conclude that that the choice of the patient position should be tailored to individual patient characteristics. They cannot, with this meta-analysis, you cannot tell that prone PCNL is superior than the supine PCNL. Now, prone position not safe for the patient, more time taking, not cost effective, anesthetists do not have control to the patient, and surgical outcome is very similar to supine PCNL. Then why you want to do a prone PCNL and putting the patient to the risky than the safer position. If you put a prone PCNL to the OT, then you will find the faces of the anesthetist, the OT staff. And if you put a supine PCNL in your OT table, you can understand they are welcoming with a 10 out of 10. Thank you.
Thank you very much, Dr. Rajendra. Very compelling arguments. But now we go ahead with the rebuttal. Dr. Vijay, we start with yours.
Yes, the screen share.
Dr. Rajendra, you need to stop sharing the screen.
Yes, sir. Wait a minute. Yes, sir.
Okay, my slides are visible, sir?
Yes, they are visible.
Okay, so coming to the rebuttal, well, I don't know if the arguments are compelling or no, since Rajendra sir has said that there are so many advantages. So let me ask this question actually, that urologists are innovators, and it has been around 30 years now that Valdivia first described his supine PCNL technique. And if really supine PCNL is so advantageous, why has it not been adopted everywhere even after 20 years? Please see the truth. And Valdivia, who was the progenitor of supine PCNL, he himself has authored this study. The Crows group, you see the reality. Actually, prone, even 80% of the people are performing prone PCNLs only. Supine is very less. What does it actually tell you? This is a large prospective cohort, mind you. Okay, 96 worldwide centers. So, are so many urologists shunning the advantages, or it's actually something else? The answer is actually that multiple cohort studies and RCTs have shown no added advantage. I have already shown the level 1 evidences. There is actually no advantage to performing a supine PCNL. The operative time which Dr. Rajendra told in RCTs, it has been shown 2 studies, significantly lower operative time actually with prone PCNL rather than supine PCNL. So the shorter operative time doesn't hold. And I'll be coming to his other arguments. And see, basically, there is no advantage to supine PCNL, but instead we are getting an inferior stone-free rate. We are making the procedure difficult. I'm sorry to say, but sir has not discussed the CT urogram. I have discussed the CT urogram and have shown what difficulties can be faced if you're doing supine, whether there is any other alternative access tract available, if you are having a bad day, if you don't get the puncture well. And even the CT pics have been shown where you can see the track length is significantly longer and the nearby viscera are significantly nearer to the kidney rather than being away. And so you are getting inferior stone free rate with this procedure, and the complications are not less. I don't know why you will choose supine PCNL. And let us go to our Bible, Campbell 2016th edition. See, this is not so easy. Many people may say that, okay, we can do in spinal, so that's an advantage of supine PCNL over prone. But a relatively high block is needed, and a vasovagal reaction may be encountered when you distend the pelvic adhesive system. And this may not be always manageable, and you may need to convert to general anesthesia. And regarding his anesthetic concerns, he told that anesthetists are not happy. Now, please look at this study. The prone position during PCNL, mind you, not any other procedure. This is specifically for PCNL. Prone position actually improves the patient's oxygenation. Oxygen level in the blood reflects both the pulmonary function and the cardiac function. They are not compromised. In fact, the oxygen level is better. So I don't know how we have got this idea. This is not correct. And regarding the giving less painkillers by doing in supine position, do you want to give less painkillers but take the risk of leaving stone fragments behind and do a second procedure again later on? I would not like to do it. And then regarding the time saved, now see, this is again Valdivia's initial paper in 1990. What he described, this was 500 odd patients. How much time he saved? All in all, between 7 and 28 minutes were saved. I want to ask, are we really bothered about this 7 to 28 minutes? How much is it really clinically relevant at the risk of giving an inferior stone-free rate? Okay. So what I think is that uh, it's not only enough to do well, but you should also know what to do and then do it well. And here in this case, prone PCNL is the way to go. I rest my case in favor of prone PCNL. Thank you very much.
Great points, Dr. Vijay. Dr. Rajendra, you need to give an answer to this.
Yes, sir. Sir, my
Yes, your slides are visible. You are audible as well.
Just a minute, sir.
Okay.
Dr. Vijay was my junior, but he is very renowned neurologist working in AIMS. He is very good debater also. So my rebuttal is first point is opposition will always oppose. Their job is to oppose, not the getting into the fact. They will tell multiple points to low down these advantages of the supine PCNL. But first and foremost is the patient safety. So there is no denying fact that supine position is safest among any other position described during the surgery, and it doesn't need any RCTs or any studies to prove that. Number one. Number two, there are different studies. One meta-analysis is by Dr. Professor Valdevia. But if you go through detail in the studies, he has mentioned why the results are in favor of prone. There are very, very heterogeneous mixture. There's 96 center. They've taken a huge number of cases. Yes, 80% cases are prone PCNL and 20% of PCNL are supine. But it is because that it is not taken up seriously for 3-4 decades, and it is only for the last decade supine PCNL is taking in a serious condition, because many time we history suggests that many time we go into the wrong path. Don't know why. And the Valdevia also in the letter to editor comment that he still surprised to see that patient urologists are going to do on prone because it is first described. Now the point of that, he wants to tell me that the CT suggests that there might be possibility that he need a supracostal puncture, but who says that supracostal puncture is not possible in supine PCNL? I quote two studies where the supine position is favorable for the upper pole puncture, because upper pole in mostly situated in the lower down area, like below the costal cartilage. So it is in fact it advantageous in supine position to puncture the upper pole, that means superior calyx, and it will be in majority cases it will be subcostal. Even if it is a supracostal, it is safe, and this study suggests that it does not add any additional risks that might provide equivalent success. Dr. Bijoy also want to emphasize that prone position is beneficial for the COVID situation, but he forgot to say that in ARDS prone position is super advantageous or beneficial, but not in a normal patient. Normal patient who are otherwise respiratory not compromised. What happens is there is reduction in the functional reserve capacity, and it needs more tidal volume for maintaining the saturation, and that causes barotrauma. So this is not beneficial, and 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 if there is any stone that can missed or that cannot be maneuvering because of the largest tract, so flexible URS can help in difficult anatomy. And he may argue that there is less roomy PCS, but this is boon, not disadvantage. Low intrapelvic pressure, less infective complications. The spontaneous stone expulsion helps in reducing time. And if at all you need a good room, the epi's of gauge around nephroscope can help you. So these are the fact, not the fiction. Supine PCNL is preferred over prone PCNL. I raise my case to the judges for the judgment. Thank you.
Thank you very much, Dr. Rajendra. Both of you have done great arguments, put in great points, and it will be really interesting to know that the result goes in whose favor. But congratulations to both of you for a great debate. Dr. Harpreet, can we go ahead with the third debate?
Yeah. Yes, Arvind, we can. So we have, we'll go, I think.
You
as
share your
Arvind-
screen.
Yeah. As Arvind has mentioned that it has been a. Can you see my slides, Arvind?
No.
Okay, let me share my screen. Yeah. Yeah. Can you see my slide, Arvind?
Yes.
I'm audible?
Absolutely.
Yeah. So as Arvind was mentioning, we had a great 2 rounds. It's really very difficult. So we move on from there. Now to coming to debate 3, it is in calculus in calicial diverticulum, I versus PCNL. Just to give a brief background of the case, it's a 32-year female, no comorbidities, complaint of right flank pain on and off since 1 year. At present, complaints of right flank pain associated with nausea. Otherwise, clinical examination, nothing significant. So you can see a 11.8 stone in the right kidney. This is the image, and you can see the diverticular here, and you can see the PCS. And for RIRS, it is Ajay, and for PCNL, it is Vasta. I will invite first Ajay to take up the case, and
I'm sharing my screen, sir.
Please.
Just a moment. May I start, sir?
Yeah, you're audible, visible.
Oh, thank you, sir. Good evening, all, sir. So myself, Dr. Ajay Agrawal from RG Stone Urology Hospital, Delhi. Firstly, I want to thank all the organizers to giving me the opportunity to take part in the second round of Crossfire in endourology. I feel very fortunate for that. Now the case as already told by you is a 32-year-old female with right flank pain with no comorbidities, and per abdominal examination is normal. CT scan, as you said, reveal a 11 into 8 calculus in the right calicial diverticula, as we can say in this image also. So the options provided to us is either RIRS or PCNL. I want to say the first thing that came into our mind after seeing such a stone in calicial diverticular stone is PCNL. Just do the PCNL and get rid of the stone. It came to my mind too. It take a lot of time to convince myself, but after thorough literature search and my previous patient experience, now I am confirmed and can confirmly say that in this case per se, my opinion is RARS would be much better than PCNL. Why so? The points which are in favor of RIRS in this case are is stone accessibility, the safety profile of RIRS, and acceptability among the patients. So we come one by one. Regarding accessibility, as we can see, the stone is present in the diverticula, and there is a communication with the calyx. So there is no blind diverticula in which RIRS cannot be negotiated. So RIRS can be easily negotiated through these and can break up the stone and remove the stone. Also, as mentioned, the stone size is 11 into 8 mm. Many studies suggest that it favors RIRS. I'll show a study. Also, the diverticular neck, which connects with the calyx, is also very short. It also favors RIRS. My presentation will be small and simple, not much of bulk of literature support or textbook statements. So I might end up early with my presentation, very limited and relevant literature. This is a literature which is support my previous statement. It is published in 2020, in this year itself, in Research and Reports in Urology. It compared the stone-free rate in calicial diverticular stones after RIRS. It suggests that stone-free rates are affected by stone size. It mentioned that the appropriate stone size is around 12 mm to 15 mm, and the length of diverticular neck should be short for increased stone-free status in such stones. Now, secondly, regarding the safety profile, as we all know, RIRS is a very minimally invasive and with minimal perioperative morbidity. to support the statement, this is a paper published in Urolithiasis in 2015. It compared PCNL with RERS and calcial diverticular stones. 54 patients were compared, 29 underwent PCNL and 25 underwent RERS. Both the groups have comparable minor complications, although the PCNL group have significantly more Clavian 3 complications. It suggests that RERS is much better in safety profiles than PCNL. Another paper in Journal of Endourology, it also suggests the same, that complications in PCNL is 18% while none in RERS. So safety profile also favor RERS in this group. The last but not the least is acceptability among the patient. In my experience, our center is RG Stone is a high load center for endourology procedures. Whenever we give option for patients for incision-less surgery or minimally incision surgery, patient instantly opt for incision-less surgery. No doubt about it. So incision-less surgery. Secondly, invisibility. As I told, RERS is a minimally invasive procedure. When we told all the complications of RERS and PCNL to the patient minimal invasibility of the RERS appeals to the patient and they opt for minimally invasive RERS. Then regarding cost effectiveness, as there is a shorter hospital stay, very short hospital stay for RERS, so it is cost effective than the PCNL. There is a paper which compare the RERS and PCNL in calcial diverticular. I mentioned it earlier also. 39 patients were studied. The average hospital stay for PCNL was 2.8 days, but for RERS, the patient were discharged on the same day. So finally, I could say that I have no doubt that PCNL is also an option for calcial diverticular stone. It's a good option, but in this case per se, RARS is much better and much favorable than PCNL. So I rest my case and I say that RARS is a much better option than PCNL in this case. Thank you. Thank you, sir.
Can you stop sharing, Ajay?
Yes, sir.
Thank
Yes,
you
sir.
for your points, and I think it's a very crisp points. May I invite Dr. Vastav to present his case?
I hope my slides are visible, sir.
Yeah, Vastav, you're visible and audible. Yeah. Speak loudly.
Good evening, respected judges and the esteemed members of USI and ISU. This is the debate of calcial diverticular calculus, PCN versus RIRS. I'm thankful to all of you guys that you have chosen me to the next level. And my greetings from Calcutta to Dr. Agarwal also, my esteemed opponent. So this is a case, a 32-year female, no comorbidities, complain of right flank pain on and off since 1 year. At present, complaints of right flank pain and severe nausea, per abdomen soft and non-tender. The CT scan suggests 11 millimeter stone on the calcial diverticle on the right side, and it's like 1100 Hounsfield per unit strong. Now, I have to defend PCNL. No, I seriously doubt, is there any debate at all? We can debate between 90 and 20 regarding the superiority, but not between 90 and 1900, I guess. So let's look into the factors to begin with to be considered for the successful treatment outcome for calcial diverticular stone. Number one is stone clearance rate. Number two is symptomatic relief to the patient. And number three is diverticular obliteration. Now, let's look what Campbell Abival says. Percutaneous removal has the highest treatment success rate of all endourological minimally invasive treatment modalities. PCNL should be considered as first-line treatment for most calcial diverticular stones, and most data supports the efficacy of percutaneous approach. Now, the Gita of endourology, Smith's textbook says that PCNL achieves high stone-free rate, about 87.5 to 100%, obliteration of diverticula in about 76 to 100%, symptomatic relief in more than 90% cases, with a durable 100% success rate. And if you look into the guidelines, European urology guidelines recommendation for calcium diverticular stone. The options listed in the sequence of SWL, PCL, and then comes RIRS. And the next statement of recommendation, they say that use flexible ureteroscopy in cases where PCL and SWL are not an option, even over stones more than 2 centimeters. So in recent very large studies like 2017, 2019, conventional surgical techniques for managing calcial diverticula are not being superseded by new techniques like RIRS, but rather being progressively enhanced and improved. Percutaneous treatment of calcial diverticula is safe, effective, regardless of size or location, with 96% success rate and only 4% complication rate, mind you. Now, to summarize, the PCL is a treatment with optimal post-operative stone-free rate, which gives an excellent symptomatic relief to the patient with complete obliteration of the diverticula. It has shorter operative time, mostly around 40 to 60 minutes in experienced hands, and mostly tubeless procedures we are performing. And hospital stay, if we talk about, is minimal. We are not talking about 90s or early 2000 data. We are talking about today. Many centers are practicing even day care procedure for PCNL. And if we talk about mini PCNL, a large review of 1279 patients says that mini PCNL provide a significant higher stone-free rate. There were no statistically significant difference between the mini PCNL and RIRS in the complications. If we dig further, we can see in larger studies and recent studies that calcium diverticular calculi can be treated most efficiently by PCNL. Stone-guided puncture and no attempt to dilate or create new infundibular reduces operative time and morbidity while yielding high stone-free rate. Mini PCNL is an effective method for the treatment of calcium diverticular calculi. However, flexible URS is an alternative technique in selected patients which produces lower stone-free rate than PCNL. Fulguration with a high power holmium laser obliterates the diverticulum. And with all this background, even if my esteemed opponent still insists to play with his magic rope, I must remind him that RIRS, the overall complication is not less, about 7.4%. In the majority of cases, it needs pre-stenting, and this statement comes from none other than Oliver Traxler. More number of ancillary or repeat procedures. And if we talk about complications specific to calcium diverticular stone, the stone-free rate is much less, 19 to 60% at the most. Inability to identify the ostium in about 1/4 of cases. And in 41% cases, eventually went into PNL, that is PCNL, with ultimate success. And who doesn't know this wizard, the guru of RIRS? Let's see what he says. Out of 38 patients, 21, that is 55.3% only, patients were rendered stone-free, and 26.3% patients had clinically insignificant residual fragments. Those are less than 4 millimeter. In another series, he says that 62.2% patients become stone-free. The success rate was considered as stone-free along with clinically insignificant residual fragment. And yet he concludes that flexible URS using holmium laser is a very effective and minimally invasive technique. Now, 4 millimeter residual fragment out of 11 millimeter stone, would you call it insignificant? At least I do not call them. And what about these graded pictures? Complication mentioned by the same master. At about 50% patient develop, 46.6 actually, develops ureteric injury. And in about 14% patients, these injuries are grade 2 and 3, which involves the smooth muscle layer of the ureter, causing ureteric stricture. Now, if you talk about the cost effectiveness, cost of disposable materials and endoscopes were 656 euro for UMP and 1160 euro for flexible URS per procedure. And cost of endoscopes and disposable materials are significantly lower in PCNL. In a metro cities like ours, its usual cost of PCNL is 70 to 80,000 versus RIR is about a lakh rupees. Now, with this background, let's look into our particular case. It is a posterior mid-calyceal diverticula with a very narrow neck. Now, in this case, straightforward infracostal or at the most intercostal puncture can be made for the PCNL, and we can retrieve the stone and obliterate the diverticula. But diverticular opening is difficult to find by retrograde approach in this particular case, and the neck is almost at the right angle with the mid-calyx infundibulum. So it is impossible, almost impossible to negotiate the bends by your laser fiber. Even if you can negotiate your scope to the mouth of the diverticula, I'm sure instead of stone removal, you will end up in making a magic knot out of your magic rope. Thank you.
So it's very interesting. Let's see how Ajay responds to this. I'm sure he has something up in his sleeve. Looking forward to Ajay's rebuttal.
Sir. Just a moment. Am I audible, sir?
Yes, Ajay, you're audible and visible.
Sir, with due respect to Basab, sir, you showed us a lot of literature support in favor of PCNL. As I have earlier said, I am not in a position of PCNL at all. PCNL is a good procedure. PCNL do a lot in such kind of calcial diverticular stone. But in this case per se, PCNL is not an effective procedure. RARS is a better procedure than PCNL. Sir, regarding your stone clearance rate, I differ. I am showing you you showed us something data. I am also showing a stone free rate. There is a paper published in Urolithiasis, RARS single center experience for symptomatic calcial diverticular stone. It shows success rate of 81.4%. You quoted the success rate of maximum to maximum 60%. Another paper, sir, efficacy stone free rate. The success rate considered as stone free is 81.6%. Journal of Endourology. So I differ from your statement that stone free rate is maximum 60%. As you have quoted in Traxer paper, it was 55.3%. So, sir, I differ from that. Secondly, you told us about cost effectiveness. Sir, in my institute, RIRS cost around 70,000 to the patient, and PCNL, if there is residual segment or in two-stage PCNL, it will cost more than 1 lakh. So for the patient, it will be cost effective. Regarding safety, sir, as I earlier said, complications are more in the PCNL. You have showed us the pictures of laser injury regarding the diverticula. So, but overall complications of PCNL is more. The diverticular rupture, all that happen in the PCNL. So safety profile wise, RIRS is also much better. And sir, you showed us the Campbell guideline. Sir, these are the guidelines. These are just to guide. With due respect, sir, we have to modify ourselves according to the case in different case scenario. Sir, so overall, I want to say that in this case, this is a big no for PCNL. And regarding one thing, sir, you showed us a chart for the excess of the PCNL. So I want to emphasize that in the CT, there is a little room for guide wire negotiation. You cannot negotiate a guide wire in that impacted calcial diverticula. So that will be difficult for dilatation. Also, you will not be able to universalize the guide wire from that diverticula. And regarding you said it is a intercostal puncture or supracoel puncture. So puncture would be difficult in this case. So, sir, in this case, RIRS would be much, much better than PCNL. So I rest my case, sir. Thank you. I'm stop sharing, sir.
Thanks, Ajay. Vastav, go ahead. Vastav, we cannot hear you. Unmute yourself. Vastav, unmute yourself.
Just a moment, sir. Sir, actually, I can see only the participants, not my screen.
Can you stop sharing and reshare? Stop share and again share your screen.
Actually, the participants panel is coming in front of the whole screen.
But we can see your slides.
We can see your slides.
No,
the
slides, actually, the slides are getting blocked by, I mean, this participants panel is blocking my view. The
okay,
whole
stop share. You must have gone into gallery view. Stop share and reshare it. Yeah. Share screen and then make it safe.
Okay. Again, the same problem is happening.
See, you change it to speaker's view. Make it speaker's view.
Arvind is right. You have gone into gallery view. change to speaker view, the things will come. Are you able to locate that, Vastav?
So now it's in the speaker view only.
Sir,
Speaker
do
view.
the standard view. There is a standard view also. If that's
That option is not
The
coming.
speaker view, gallery view, full screen. So I think you should be in speaker view, right?
Can Mr. Aditya from the AV help him?
Ravi, anybody from the support group?
Can you see
Hello?
now?
Sir, can you please click on share screen button? It's at the bottom of the screen, sir.
Can you see my slides now?
No.
No, sir.
No.
Please start your presentation first. Is it open in the background?
Yeah, it is open in the background.
Now can you come on Zoom and click on share screen, sir? Bottom, it's at the bottom.
Yeah, the problem is that whenever I share the screen, the panel is coming in front of me and it's blocking my view.
Okay, now we can start seeing it.
Yes.
No, but I mean, my screen is blocked by the entire this.
Yes, sir. You will not be able to see your screen, sir. You will be able to see just the presentation. Can you click on slideshow? It's at the top.
No, can you see?
Yes.
sir.
Okay.
We can see and hear you,
So sorry.
Vastav. Go ahead.
Yeah.
Okay. I'm sorry for the technical glitch. Now, at the beginning, Dr. Agarwal has said that he wants to. I mean, he has a gut feeling that he should go with. Yes. He has a gut feeling that he should go with the PCNL. Many a times we should go with the gut feelings, because that is gut feeling is made by your knowledge and whatever we will learn over the years and ages. Now, one paper he has quoted this particular this particular study, that complication is more, but I would like to tell you that this study was a little bit biased, as the average stone burden prospectively preoperatively was significantly larger in case of PCNL group. Now,
Can you stop background noises, please? Everybody mute yourself. Yeah, thank you.
now, in another large studies, we found no significant difference in operating time and the length of hospital stay. He has quoted a study of 2002, an Auge study. That was 2002, and we are now in 2020. So these are pretty old studies. So probably these newer studies should be considered. And if we talk about stone clearance rate, was much superior in percutaneous nephrolithostomy versus ureteroscopy. And all the recent studies are saying that stone clearance is much more higher. And as we miniaturize the PCNL, then probably the complication rates has come down. And in this particular recent study also, this is a large tiny study, the stone field is much higher, symptomatic improvement is much higher, complete divertical obliteration much higher, and complication was 19% versus 13.3%, and which is clinically insignificant. So I just want to tell you that all these things are headgears. That is, the goal is to protect the head, but it is about the appropriateness that serves the particular purpose. So as he also mentioned, that in this particular case, it is not about the generalized knowledge or generalized idea with the PCNL or RIRS should be done. As I mentioned, that this bend cannot be negotiated by laser fiber. So I would go for PCNL. And regarding the puncture, all the calcium diverticular stone have the problem of parking the guide wire, but still the points in favor of like stone free rate and calcium obliteration are still there, considering all those like drawbacks they have found, and probably this is called appropriateness. Thank you.
Thank you, Vastav. I will say it's really a very challenging debate, and both have presented beautiful arguments. Let's see. I will wait for judges. Move to next, please. Share my screen. coming to the last, sorry. So now we're coming to the last debate. Debate 1 has become debate 4. ESWL versus PCNL, left renal calculus in a 6-year-old child. So 6-year-old male child complained of left flank pain on and off since 6 months. No other complaints. Renal function normal. You can see a stone at 4 into 11 mm, right? So this is the excretory urogram or CT urography. It's a well-dilated system. So we have Kawaljeet for ESWL and Dr. Shashank from PCNL. So I will invite first Kawaljeet to lay down his points. I'll stop sharing my screen.
Yeah, good evening, sir. Am I audible? Yeah, am I audible to all, sir?
Yes.
Yeah, I'm just sharing my screen. Good evening to all. Is my screen visible, sir?
Not yet. Yes, Kawaljeet, we can see your screen and hear you well.
All right, without wasting time, I'll just proceed with the case. The case has been already explained by you, sir. I'll be taking up my case in 3 steps. I will discuss pre-procedure factors, and post-procedure factors favoring ESWL in this case with evidence. So let me start with all the 3 factors. Pre-procedure factors I will take up include age, stone size, number, stone location, skin to stone distance, mean stone density, that is HU, technical issues, radiation exposure, intraoperative fluid absorption, procedure duration will be procedural factors, and post-procedure factors I will take up. They include hospital stay, stone-free rate, complications, retreatment rate, and financial viability. Let me start immediately with age. How age predicts ESWL success. I will quote the study 2012 Journal of Urology on 164 pediatric calculus patients. The study clearly depicted that overall stone-free rate with ESWL were higher in less than 6 years group, and mean stone, the stone-free rate with first session of ESWL were higher in this category. So these were having higher stone-free rates, and similar findings were corroborated in this study from my alma mater KGMU Lucknow, published in 2018, that concluded that comparable efficacy, that is the efficacy of ESWL is better in children compared to that of the adults. I have quoted these 4 high-quality studies depicting the age cutoff criteria, which depicts successful ESWL outcomes in children. And these cutoffs were 7.5 years, 7 years, 6 years, and 5 years in these studies. And our index patient clearly falls in this range of age. Next is stone size, number, and stone location. EAU 2020 guidelines, less than or up to 20 mm stone, ESWL should be preferred. AUA guidelines, less than 20 mm, ESWL or URS. 2016 AUA and endourology guidelines, pediatric stones less than 20 mm, ESWL and URS. PCNL is nowhere in these guidelines. I have quoted these 3 high-quality studies to suggest or to predict the stone cutoff size, which predict the successful outcomes of ESWL, and they were 11.5, 10 mm, 11 mm, and our stone clearly matches with that, and hence chances of stone fragmentation. These 3 studies, they were having nomogram studies, and they clearly stated that presence of a single stone is a favorable factor for stone clearance in pediatric ESWL. Now, next 2 studies I'm quoting is to reveal the stone location. This study in 2003 from World Journal of Urology clearly stated that renal pelvic stone patients have up to 95% of stone-free rates. Similar study from Badway et al. 2012 clearly stated that renal pelvic stones cleared up to 90% of stones with lesser retreatment rates. Thus, I feel like our index case perfectly fit into these criteria. Now, next point is skin to stone distance. This good review from Journal of Endourology clearly stated that ESWL is the effective option in children compared to adults because of lesser length of child's ureter, which compensate for its narrow lumen. Pediatric ureter is more distensible, allowing easy passage of stone fragments, and small body volume and shorter skin to stone distance, allowing shock waves to be transmitted with little loss of energy. Next factor is HU, that is stone density. Different studies have quoted different ranges, values ranging from 500 to 1200 Hounsfield units, and these 3 studies have quoted up to 1900 and 1000 ounce per unit, and our stone is around 1150, not far away from that, and chances of fragmentation. And above all, this range include dihydrate stones, which are relatively softer compared to that of monohydrate stones. Now, let me take up procedural factors, technical issues. Why not PCNL in this particular case? Stone is around 11 centimeter, 10, 11 centimeter size in this child, and dilatation is not that. It's minimal dilatation, which will predispose to high chances of complications like bleeding and system rupture. And the middle calyx infundibulum is narrow. The chances of puncture from this calyx will be lesser one or complicated one. Inferior and superior calyx can be punctured, but the angle, I feel like it will not be appropriate for reaching the stone and fragmentation, which can result in more of the complications. Why favoring ESW in this particular case? It's a single stone, around 10, 11 centimeter stone. It's a pelvic stone, 1,000, around 1,000 ounce per unit on CT. Into stone distance less than 10 centimeters. There's no renal anatomic abnormality, and there's favorable pelvic angle, which will help in easy drainage of the stones down the gravity. Also, technical factors like appropriate coupling and starting from lower shock waves and ramping up protocol of the voltage and adequate shielding will help in stone fragmentation in this particular child. Next factor is radiation exposure. It's a serious concern in PCNL. This study clearly states that the total radiation dose of around 32 MSV compared to 20 in SWL. This is relatively lesser in ESWL nowadays because of more of ultrasound use. And we all know the permitted radiation exposure. And children we know are more inherently susceptible to the radiation hazard because of high dividing cells and high life years ahead. So it's a serious concern in PCNL. And this finding was corroborated with this meta-analysis and systematic review, which clearly depicted longer fluoroscopy times in this patient. Next is intra-fluid absorption. We all know fluid is absorbed in PCNL, and this is a beautiful study from Journal of Endourology clearly stated that average around 180 ml of fluid is absorbed in procedure PCNL per procedure, which increases with bleeding or with perforation. And just imagine if this fluid is absorbed in a child, it can be disastrous, resulting in hypothermia, coagulopathy. Next is operative time of procedure duration. This is a study from EAU clearly depicting that more of mini PCNL being used nowadays in pediatric patients is resulting in longer procedure time, resulting in higher complications like acidosis, etc. Similar findings were corroborated in the systematic review and meta-analysis that longer operative time leads to higher complication rate. Let me straight away proceed to post-procedure factors. And first, I will take financial viability because it matters in India. There's a beautiful study from 2019 from Turkish clearly stated that $85 for 3 sessions in SWL and 1 session of PNL, $500. This means something. And let me take these 4 factors together now. And this table speaks in itself. These are reliable sources. And Campbell urology, stone-free rate in PCNL up to 90%, ESWL 68 to 91%, depending on stone size. Smith endourology, 85 to 100%, 73 to 85% in ESWL. EAU 2020, 71 to 95%, almost similar. So ESWL doesn't fare that bad in terms of stone-free rate. Now let's talk about complications. PCNL, Campbell urology, 15 to 20%. Smith endourology, 31%. EAU 2020. This is unacceptable. Similar, this table explains everything. Higher rate of complications, higher cleaving grade complications. Similar finding in EAU, higher cleaving grade complications. Similar findings in this matter. This head-on-head analysis between in such a similar index patient, higher rate in stone clearance in ESWL up to 92.5%. None of us would like to see these kind of complications in our patients. So we want to be as safer as possible in children and want our patient to be discharged in a happy mood. So I would like to conclude saying that ESWL is the norm in this patient because it's minimally invasive, shorter hospital stay, less overall complication, no bleeding complication, no pulmonary injury, no comparable stone-free rate to PCNL, no low risk of radiation, no risk of intrafluid absorption or hypothermia, no long-term risk of renal loss, and PCNL. Why not in this case? Highly invasive, longer hospital stay, high complications, high risk of radiation, high intrafluid absorption, 5% long-term focal risk loss. I conclude by saying that ESWL should be preferred in this case because it is safe and it has stood the test of time. Thank you.
So very well, Kavaljit, you have laid your points. Sashank has to defend it. Tanuka?
Yes, sir.
You can share your screen.
Is my screen visible, sir?
Yes, you're visible and audible. Go ahead.
Right. A very good evening to the respected convener, sir, the regional moderators, the respected judges, my respected seniors, and all my colleagues. So we are debating the management of a left-sided renal calculus in a 6-year-old child. And I'm talking in favor of PCNL. The case summary has already been discussed. And we know that it's an 11 millimeter stone. So very conveniently, my learned colleague has just labeled it as a 10 millimeter, around 10 millimeter. And the Hounsfield unit is 1150. It's been given for a reason. And he's very conveniently called it around 1000 Hounsfield unit in a couple of slides. So that is a thing that we'll keep an eye on. It's a dense stone, no denying that. All right, the anatomy does not look bad. There are a lot of calyces and it's a fairly good system, good infundibulum. I don't think the anatomy looks bad at all. It's very inviting to do a puncture. So going to evidence, starting with the textbook, the Smith's textbook of endourology, reaffirms about the safety of PCNL in pediatric patients. They found it to be safe and efficacious compared to matched adult cohort with similar rates of second loop nephroscopy, length of stay, and complications. In a large review of over 600 children, PCNL was found to have superior stone-free rate of 85 to 100%. Now, I noticed in a few slides, my learned colleague mentioned about the success rate of stone-free rate of ESWL in the higher 80s and 90s. But we all urologists know that the truth is all the data and all the real experience brings it around 60 to 70%. So this is a paper in our very own Indian Journal of Urology by Dr. Arvind Ganpule, who had outlined about PCNL for pediatric urolithiasis. And they concluded that PCNL offers good clearance rates in a single hospital stay. Now that is a very important point with a 6-year-old boy. And they mentioned about miniaturization of instruments, particularly smaller scopes, and the potential to use lasers will decrease the morbidity and improve clearance rates. Mind that this publication was in 2010, and we are in 2020 now. In these 10 years, as they rightly predicted, we have a very good choice of mini nephroscopes, about 12 French and 14 French. We've got excellent choice of sheets of various sizes. We've got excellent energy sources, including the 100-watt holmium laser and including the newly launched super pulse thulium fiber laser. Each of these does a very effective job without any damage to the adjacent tissues. This article is one of the best ways to understand this situation. It's a systematic review. It's the highest level of evidence, a level 1 evidence. It discusses about which is the best treatment of pediatric stones amongst ESWL, PCNL, and RIRS. So we'll take each point and look at the real facts. Overall stone-free rate and single-session stone-free rates were much, much higher in PCNL, significantly higher. And as you can see from the forest plot, this clearly favors PCNL in both the overall as well as the single-session stone-free rate. No debating this at all. Looking at the complication rate, so a lot has been said about complications of PCNL. With the improvement in our scopes and energy sources, there's no significant difference in complication rate among the 3 procedures, and this is what the meta-analysis has concluded. Regarding retreatment rate and auxiliary procedure rate, now this is the point of worry. When you're subjecting a child to an ESWL and he's got a dense stone, 11 millimeters, ESWL exhibits a significantly higher retreatment rate and a higher auxiliary procedure rate. There's no doubt about it. The plot goes way in favor of PCNL. There's no questioning this. And you don't want a child coming back for retreatment and auxiliary procedures, and each time under GA. Effectiveness quotient, no doubt about it. PCNL had a higher efficiency than ESWL, and the forest plot says the same as well. So the conclusions that this study drew was, regardless of the selection of treatment modalities, we all agree that the final objective is to render the patient stone-free and to reduce the recurrence risk to a minimum. So we know that this is a child. He may be having a metabolic abnormality or an infection which is causing the stone. We don't want to break the stone into bigger fragments and leave those fragments within his system just to come back with a recurrence. A randomized control trial conducted by Kumar et al. Proved that PCNL was more efficient for stone sizes of 10 to 20 millimeters than ESWL. And identical conclusions were reached by other case control studies as well. So considering the lower retreatment rate and auxiliary procedure rate, these studies concluded that PCNL is a feasible and more efficient treatment for pediatric renal stones. On the other hand, the biological effects of ESWL are well known to all of us, and there are lots of studies that have investigated the acute effects of ESWL and the long-term effects on the kidney tissue, like focal hemorrhage, rupture of small veins, extravasation of blood, necrosis, disintegration in the podocytes, ischemic changes, and we have lots of images which are widely available showing post-ESWL subcapsular and perirenal hematoma occurring because of this procedure. This publication talks about PCNL experience in a developing country from the World Journal of Urology. They agree with Lim and co-workers' opinion that in cases of dense stones above 10 millimeters, now this is exactly our kid, primary PCNL is the preferable method in the pediatric population. This is an excellent statement made in this paper. In their series, one of the reasons for failed ESWL was a calculus greater than 10 millimeters in size. Their stone-free rate was a dismal 46%. And our 100% success rate is much higher than that, which can be reached with ESWL. Although ESWL is a less invasive procedure, its clearance rate is also less well known to all of us. This publication from the Arab Journal of Urology looked at the success of ESWL on the basis of the stone attenuation value. And in this study, they divided the patients into three groups. The first, less than 500, the second, 500 to 1,000, and the third, more than 1,000. The clearance rate was only 44.6% in the group 3, that is our patient. So the stone attenuation value is an independent predictor of the success of ESWL and a useful tool for planning stone treatment. So patients with a stone attenuation value greater than 956 ounce per units are not ideal candidates for ESWL. This is what planning is all about. Summing up, we have a kid who's got an 1150 ounce per unit stone, so we cannot blindly follow conventional old guidelines which are there to just guide, but we have to individualize our treatment. ESWL is more likely to form fragments and not dust. It will require GA and likely multiple sessions of GA. Already from data, you know that it will require auxiliary procedures like DJ stenting or URS. There is a risk of adjacent organ injury in ESWL because children are more susceptible to this type of injury. On the other hand, PCNL in a single sitting GA can give us complete clearance. A mini PCNL in one puncture damages only about 100 nephrons, which is negligible. And multiple studies and meta-analysis have reaffirmed its safety and efficacy in children. Advancements in instrumentation and energy sources has led to fewer complications in the last 5 to 10 years. So the choice is very clear. On the one hand, we've got a one-stop, sure-shot, minimally invasive solution with 100% clearance. And on the other hand, you've got multiple sessions of apparently less invasive treatment prone to auxiliary procedures and residual fragments. Which one would you choose? I think the answer is very clear. Thank you.
Well, Shashank, well said. Let me hear to Kawaljit what he has to say. I'm sure.
All right, sir.
There's a lot of bullets there.
I'm sharing my screen for rebuttal.
Little loudly, Kawaljit. Yeah.
All right. I am sharing my screen for rebuttal, sir. Yes.
You can see your screen, Kawaljit.
Is my screen visible, sir? And I'm audible?
Yes, Kawaljit. Little loud. Speak little louder.
All right, sir. Am I audible? Yeah.
Yes, you're audible, Kawaljit.
Okay. Dr. Shashank has beautifully highlighted the Hounsfield unit and stone-free rates. I would like to clarify that I am not against PCNL as such, sir, but in this patient, why I am favoring, I have already given you a lot of literature, but Dr. Shashank is still not ready to listen to me. You have talked about number one in the factor that long-term implications of shock wave lithotripsy on renal function and other factors. This speaks in itself, this slide. This table is from Campbell Walsh Urology 12th edition, and clearly it stated that there is no evidence of long-term hypertension, chronic kidney disease, diabetes. All a few of the slides that you have shown, the pictures, they are all short-term outcomes in a safe and non-invasive procedure like PC and ESWL. And a lot of studies, a lot of literature is there, but this table highlights in itself the safety and the long-term safety of ESWL, which you were talking of. Second, I would like to, before I proceed on Hounsfield unit, I would like to clarify that I have already stated there are a lot of studies which have mentioned there is a range of 500 to 1200 Hounsfield units. And mind you, this range is of dihydrate stones and it is a relatively softer stone compared to monohydrate. The chances of fragmentation in this range are also there. Let me take you to ESWL study 2019 of 2000 patients. This was a study of 2000 patients, and see the overall success rate 82.6% in this. You are talking about 50 to 60%, and see the complication rate 5.8%. You are talking about PCNL. I have already shown the slides. Let me take you to that slide first. This is another beautiful review version of urology. You clearly see HB drop requiring transfusion 24%. Is it acceptable in case of a child of this age? You're talking about sure shot procedure in one go, but this sure shot, no parent would like to accept the sure shot at the cost of the complications. In ESWL is a procedure where it is a procedure in which we already dictate the patient beforehand for the steps to be needed. So we have to understand that safety should be the priority, and stone-free rate, although higher in PCNL, I accept, but not at the cost of the complications. This I want to highlight. Another World Journal of Clinical Pediatrics, see, clearly it has stated that PCNL use has limitations because it has a parenchymal damage. It causes renal function loss, radiation exposure, bleeding, and septic complications, and should be used in more than 15 mm stones, not around 11 mm stone in a child of this age. So clearly, this is again a similar review. These are the 4 points I would like to highlight. Stone-free rate of ESWL range from 68 to 92. ESWL should be chosen for pediatric patient less than 2 centimeter. EAU guidelines already highlighted. PCNL is a challenging procedure in this case because of small kidney, longer operating time, and low tolerance to blood loss. How would you explain complications, blood loss, intraocular fluid absorption? In the end, I would like to quote the Bible of Urology, Campbell. I would like to read few points. It has clearly stated that SWL and URS is a treatment option for upper trach 15 mm stones, less than that in children, more than 20, go for PCNL. PCNL is technically challenging in kids' kidneys, and despite its efficacy rates, PCNL is associated with risk of complications, including bleeding and all hemothorax, urothorax, etc. The risk associated with PCNL must be reviewed with the consenting parent. You have to make the patient consent that you have to go for surgery, which has a 20 to 40% complication rate of, and the rate of bleeding with requiring transfusion up to 24%. And because of this possibility, this should be performed at the specialized centers only capable of handling all these procedures. So I would like to arrest my case saying that it's a procedure which has stood the test of time. It is the procedure which is economical. It is procedure which is safer with less complications. But stone-free rate, although I agree that it is higher compared to in PCNL, but it should not be at the cost of the safety of the patient. So I arrest my case saying that ESWL should be preferred in this case. Thank you very much.
Yes, Sashank.
Sir, am I audible?
Yes, Sashank, go ahead.
Right. Okay. I like
make it full. Make it full.
Yes. I like the political inclinations of Dr. Singh, and also the monkey who is not ready to listen, as he pointed out. But the fact is, evolution is everything. I mean, if a person is not evolving, that person is not ready to listen. So this is a fantastic paper by Dr. Sabnis and the team, including Dr. Ganpule sir, about the current role of PCNL in pediatric urolithiasis. And the very purpose of this debate is to understand that what is the increasing role of PCNL in the kids today? Because if we were just going to go by guidelines, this would not be a topic of debate at all. I mean, EAU, AUA, Campbell, these guidelines are very generalized guidelines, and we are debating it because there's something more than this. We need to choose, we need to understand that endourology is evolving, and we have to understand PCNL offers a number of distinct advantages. Within the last few years, there have been improvements in radiological techniques, particularly CT, with dedicated reconstructions. There's been miniaturization of instruments. So all the complications that Dr. Singh is talking about, 24% hemoglobin drop. All right, please forgive me. For a mini PCNL, 11 millimeter stone, that is going to be a very rare occurrence, Dr. Singh. even for somebody who's doing very few cases. And the smaller scopes, the laser, a mini perk approach, even the micro perk and ultra mini perk, which most of these things have been developed in India and mastered by all of our colleagues. So they have shown that there's a decrease in the morbidity and it still affords a very high clearance rate. So our patient is a child. We know that he's definitely got some metabolic anomaly or infection, and there's a chance of recurrence. So residual fragments is one thing that we don't want to leave in this child. And there's always a chance that he's going to come back with more stones and more episodes. He might need procedures in the future. And we're also bothered about the global renal function of this child. The stone that he's got right now is an 11 millimeter stone. The density is fairly dense at 1150 ounce per units. As shown by multiple studies, the stone size and stone density are very important predictive parameters regarding outcome of treatment and should be used to choose the appropriate mode of treatment wisely. The number of procedures under GA. All right. I think he quoted some financial data from Turkey. I mean, I was working in the UK till the last month, but when we are in India, I think PCNL is one of the cheapest procedures that you can offer to a child, to a patient. And $500 or something for a PCNL. In India, a PCNL would cost something like 60,000 rupees, whereas multiple sittings of PSWL under GA, along with DJ stenting plus minus under GA, along with the need of a URS plus minus to remove those fragments, I mean, this cost is going to go beyond the lakh rupees. ESWL with its low stone-free rate results in multiple sessions under GA and the need for auxiliary procedures, which adds to the morbidity as well as to the cost. PCNL, on the other hand, affords a single sitting procedure and ensures complete stone clearance at a nominal cost. Modern mini nephroscopes and laser, as I said, you need to understand that there's been a lot of evolution in endourology. You just can't be in the 2000 or 1990s. This is 2020. The endourologist's armamentarium is now equipped with mini nephroscopes and laser, and we've always embraced evolution in endourology. So I would conclude saying that it's evolution, and you need to listen to evolution. You need to listen to the world, what's going on in the world. You just can't shut your eyes and ears, and the choice is very clear. PCNL in kids is a very safe operation, and for this stone, it's the best option. Thank you very much.
I thank all the debaters. It's a really wonderful listening to all of you. I'm sure you all have put point, counterpoint very effectively. You have quoted the literature extensively, really impressed by all of you. I'm sure judges are going to have a hard time in picking up the things. And I thank Arvind for giving me this session. Listen from the innovators. It's really a privilege to moderate this session where teachers of teachers will be talking. The first speaker in the Listen from the Innovators scheme is Dr. Mahesh Desai. Mahesh Desai sir needs no introduction. He's our past president of USI. He's a teacher par excellence. And there's numerous publications, numerous workshops done by him. He's my teacher also. So let's listen to him. How did the idea of microperk occur to me? Can we have his slides? Runa? Aditya?
Yes, sir. Playing the video, sir. 1 second.
Right, thanks.
Greeting from Nadia. Stone management has drastically undergone a change since 1980 with development of minimal invasive surgery, ESWL, PCNL, and urotoscopy. In somewhat, there was an era of ESWL first, followed by improvement in the urotoscopy, and then the PCNL was always there. And then that the way the stone was managed. But one of the main problem was the residual stone. it was very difficult to have 100% clearance in all the patient. That 100% clearance varied between say 60 to 70% in ESWL, 80% in flexible ureteroscopy, and probably 80 to 90% in PCNL. And still a awkward small stone left behind. And that was a problem because that became a nidus for another stone formation. So those small stone previously we tried to deal with ESWL. So combination PCNL and ESWL, or ESWL multiple sittings, or you do ureteroscopy and the residual stone can be do the second sitting or ESWL. But what we thought at that time, sometimes the stone is in a very awkward position. It doesn't get cleared so easily, especially in the lower calyxal residual stone or any residual stone in any calyx. But so I thought that if we can puncture that calyx containing the residual stone, then, and if with the presence of laser we can break the stone and flush it out, probably would have a significant clearance of the stone. That's why I developed this microperk, and here you can see that the needle is very small, and it's a 14 gauge needle, and then you have a telescope which is 0.9 millimeter. Let me take it out. And this is a telescope 0.9 millimeter, which is a flexible, and then you can use, and then you can, once you are inside, you can use a three-way where you can pass a irrigation, a telescope, and laser fiber, and then you can break the stone. So idea of having a microperk was primarily to tackle the residual stone. But with the success of breaking the stone, then say, why not use it for a small stone? A 1 centimeter stone. So in that case, we use a cannula, and then we could drain it. We could suck it out, the gravel. Like say this is the cannula where you can pass into the system, and then you can use the microperk with the suction, and you can, whatever is broken is sucked out. And similarly, this is the one which is quite flexible, and you can use it and then you can suck out small fragment, especially in children where the collecting system is quite compact. We could use the microperk to break the stone. If usually stones are small, 1 centimeter or maybe 2 centimeter. I have done a 2 centimeter in children in a pelvic stone and through the microperk. And these stones are soft. They just go into a dust and they clear it up. So microperk basically was developed as an adjuvant to any of the energy like ESWL, PCNL or ureteroscopy, and to deal with the residual stone. And children, you can use it as a primary.
Thank you, Ms. Sir, for sharing your thoughts, how the idea came to you, and what are the uses of the microperk. Moving to next talk, to Janak Bhai's talk. Janak Desai sir is a very, very passionate guy, and he keeps on evolving a lot of things. And I will invite to share his idea, how the idea of UMP came to him. Can we have Janak Bhai presentation?
Thank you, Arvind, for asking me to speak about how I developed Ultra Mini PCNL. Essentially, two observations. When we were doing those PCNLs, we realized that when we were doing the initial Teflon dilation, the bleeding was minuscule. But the moment we switched to the larger dilation, sometimes there was bleeding that we saw when we pulled out Amplat's dilator to be exchanged for the next. So we realized that if the dilation is restricted, the bleeding is less. So that was the the first observation, which we could prove on our nephrectomy specimens. Back then we did nephrectomies, partial nephrectomy concept had not picked up, and therefore we tried it on those specimens immediately by trying out those dilation, and there was a lateral tear which you can see in this picture. Okay, so that was one observation. The second observation was that of a whirlpool. That when you see a whirlpool, it pulls those small objects into the center and throws it in the center. In my case, we created this whirlpool and the stone fragments were engaged and it would pull the fragments and bring them out. So these were the two original concepts in my mind. And a chance meeting with Mr. Werner Scholey, the owner of the company, who was visiting India once, and he showed me a mammary ductoscope, a very thin telescope which was used as a mammary ductoscope in China. And I told him, can you make it a little stronger, maybe a little thicker, 1 millimeter is what he finally produced. And this is the telescope he gave it to me, the initial version of the telescope. Finally, we had to think about the initial prototypes, which I made it in India, a single small tube on which we stuck a pediatric catheter to create that whirlpool, which was later on made a little, it was refined a bit, and we welded a small thin tube in India. Of course, the quality was a little rough, the welding was not too good, and we made some videos and sent it to Mr. Werner Scholey. In their R&D department, they thought that this was a project worth pursuing, and he came up with the final version of UMP, of course with a few prototypes, and each time a prototype was being given, it was printed not for human use. So we made several such prototypes, and finally the final version, in which this is the UMP sheath with a side tube which will create that whirlpool by injecting saline, and everything is pulled out. And CE certification was obtained, subsequently FDA approval was obtained. And now it is already marketed in the United States by Wolf, because Scholey will not market themselves, it's an OEM company. So Scholey does not market, and therefore we are here with the final version, a 11 French sheath which is yellow coded, a 13 French sheath which is green coded, and a longer version for those obese patients in which this sheath is long, which is good enough for the obese patient. So these are the three sheets that would come in a standard set, and the rest is been shown in several workshops across the world. We have done workshops now in almost 35 countries across the world, and a chapter in the Smith's textbook of urology, and we have publications in the British Journal, in the Journal of Urology, and the World Journal of Urology. So thank you once again. Miniaturized PCNL is something which came from India. 22 until the micro PCNL, all those concepts are Indian concepts which are being now pursued by a lot of urologists across the world, and that gives us a lot of happiness. So thank you once again.
Thank you, Janak Bhai. Listening to, we realize that how much efforts go behind the back to bring something to the table. So it's a lot of midnight oil has been burnt, a lot of innovations has gone, a lot of things have been rejected, and then the final product. Congratulations to you for the same and making our country proud of it. Moving to last talk by Kaushik Bhai, who is a good friend. We have shared the sessions together many times, even the workshops. May I invite Kaushik Bhai to share his idea of his super perk. Can we have his presentation, please?
The Superwork is a continuously evolving technique. It started with alkene scala, later 10 French sheet size, then 12 and 16 French sheet size, and expanded to all track sizes. The idea of Superwork came during this conference. The Microperk and UMP were the talk of the town in that workshop. They being costly gadgets, it was difficult for most people to duplicate the results. On way home, I thought of how to go ahead with this technique. At home, I realized that alkene cannula is a 9 French through which my Wolf 4.5 French rotoscope goes easily. I have a laser, I'm good at RIRS. So in case of doing PCNL, after putting alkene cannula, I inserted my ureteroscope via cannula, saw the stone, and started fragmenting the stone with a laser. I gave a wash via ureter catheter to remove the fragments, and all the fragments were coming out easily through this. I tried to duplicate the results by using the same technique in number of cases. The results were fantastic. The advantage which I got while attempting this technique was that I had not to buy any new equipments. The track size was almost the same. I was able to use 0.8 mm pneumatic probe, biprong and triprong forceps. I can go in all calyces, even in upper ureter, and the stones were removed on table. I presented my work in SIU program with the blessings of Mahesh Bhai, and I named the technique as Superperk. However, the biggest challenge was a fragment removal. I wanted to add a suction, so after brainstorming, I came up with an idea of suction outside the nephroscope and retrograde irrigation via multi-hole ureter catheter, and 10 French sheet size assembly with a suction master was added in armamentarium. With the success of this procedure, I was invited by Dr. Mahesh Bhai and MPH team to demonstrate live at Doha, Qatar, and in an annual conference of American Urological Association. I was pleased, honored, and mesmerized. However, the journey was ongoing. I wanted a company to produce quality products and a platform for ongoing research and development. So USA Enterprise was started. It came out with a number of products under my guidance. 12 French, 15, 18, 21 and 24 French sheets were made as per the request of number of urologists so that they can do all sizes of stone with whatever they have. Suction machine with a low power and a bottle with a tap and a stone catheter bottle was also developed to sort out the problems of using suction while doing this procedure. So this whole system develops something like this. Multi-hole ureter catheter is inserted in the upper tract. The sheath is inserted. The suction is controlled by the air opening and the suction tube attached to it. You can use any nephroscope. You can use laser. You can use pneumatic, and the whole procedures can be completed. After getting this success, now our aim is to refine further this product and to solve the other problems in PCNL like puncture technique and different nephroscopes and so on and so forth. Thank you.
Thank you, Kaushik Bhai, for sharing your thoughts. It's really incredible to note how you began your journey in a very modest way and ended up giving us our own Indian technology to us. Thank you, sir. I hand over the session to Arvind for the further deliberation.
So all of you must be keenly waiting for the results. And before I declare the results, I would like to let you know that we have got 720 audience for the debate program across the three zones. The maximum audience was there in the resident Zoom ID, amounting to approximately 230. And in the rest of this one, it was approximately 220 to 230. So it was an very good participation from the USI members. Again, I must thank two people, particularly two group of people, particularly the seamless AV that we have got from the IPCA team. I must thank them. I would again fail in my endeavor if I say, if I don't wait for a second and thank the juries for bringing out the results and marking the winners in such a judicious way, and in such a fast and efficient manner as well. I must really thank both the juries for the same. And now comes the time for declaring the results. Uh, uh, in between the debate, in between Saptarshi and Akshay, Saptarshi has won with 41.5 marks, and Akshay has secured 33.5 marks. So congratulations, Saptarshi, and you go on to round 3 and later on into the grand finale. In the next debate, Dr. Vijay has secured 28 marks, while Dr. Rajendra has secured 33.5 marks. So Dr. Rajendra is the winner, and he goes on to the next round, that is round number 3. I would say that debate number 3 in between Dr. Ajay and Dr. Bastav was the most closely contested debate, and both of them have secured 38.5 marks, both of them, Ajay as well as Bastav. But as I had mentioned in my particular email communication, that in the instance of such an tie, the marks that have been secured in the content and the literature section would be given preference. So given that particular thing, Dr. Ajay Agarwal has secured more marks in that, and hence Ajay is declared as the winner. So he goes on to the next round. Finally, coming to the debate between Dr. Kawaljit and Dr. Shashank. Dr. Kawaljit gets 38.5 marks, while Dr. Shashank secures 42.5 marks, and hence Dr. Shashank is the winner. So again, I'll let you know that the winners for the round, which will go to the round 3, are Dr. Saptarshi, Dr. Rajendra, Dr. Ajay, and Dr. Shashank. I must say congratulations to all, but definitely somebody has to win. So the winners go to round 3. As far as the round 3 goes, the round 3 is the next Wednesday, that is 23rd of December. It will be at 6:30. Round 3, as you might have gone through the brochure, that there will be actually two parts of round 3. One will be that we will be contesting with the winners of the West Zone and South Zone contest, and out of that, 4 debaters would go to the next part, that is the final round, in which in the third round we are going to have a balloon debate. Means the format will be a little bit different. I'll be letting you know. All the winners will get a communication by tomorrow morning, in which we'll be giving you the cases, and then we'll go ahead from there. Again, I thank you all for your active participation, and take care. Thank you very much.
Thank you. Good job. I congratulate all the winners. And Vastav, don't lose heart. It was an excellent presentation, but I think somebody has to move forward. So Ajay, congratulations, and it's a really a great thing. Thank you. I thank Arvind for giving me this opportunity to really moderate. I really thoroughly enjoyed. Thank you, everybody. Thanks.
Thank you. Bye bye.
Dr. Aruna.
Thank you,
And
Dr. Ajay.
support team Aditya, Ravi. Thank you for your support. Aditya, thank you.
Thank you, sir.
So we're taking bye
Thank
bye
you, sir.
from my side.
Andrew.
Good night, sir.